Perfect, Kazadi.
Okay. Thank you very much, everyone. Thank you for inviting me to talk about that. I'm just going to the first slide. Getting there. It was on the first slide, but it moved. But okay. Good, there we are. Okay, thank you very much. I'm going to talk about the supraorbital approach to pituitary tumors. But before that, I'll tell you about the background, why we developed this approach. First of all, it's an approach which was described long ago. In 1,900 years ago, Krauss first demonstrated the supraorbital approach. In the 1913, Frazier advocated the supraorbital ridge resection. And in 1990, Pernesky and colleagues popularized, this concept. And more recently, Jane and Delachaux. Those are things which are well known. In our environment, until 1994, we didn't have much data, and few papers were published about pituitary tumors in Zimbabwe, but also across Africa as well. The reasons were obviously because the CT scan was not just yet popularized in all countries. And also there was an awareness about the pathology and including, of course, the technology and instruments, of course, to perform those operations. Yet we know that 21% of brain tumors were pituitary tumors. And we did this study on a 3-year period. As you can see, the number of patients, 37, 42 patients, case notes were retrieved. And the mean age was 43, and there were 22 females and 15 males. 82% of were Blacks. As you know, in Zimbabwe, it's a mixed population. 83% of were Blacks, which represent the normal distribution of the population. And the referring doctors were mostly practitioners and ophthalmologists. General symptoms patients presented with were headaches, mostly, then blurred vision, and eventually tiredness. But the reason really why they came to our consultations is because of decreased libido, galactorrhea, secondary amenorrhea, and depression. There was a lot of delays in the diagnosis. Average was about 4 years when we went through the clinical history. And the main clinical findings was when patients were losing the vision, that's where really they came, and that was present in about 85% of the people, and followed by other symptoms. And unfortunately, we had 8% of patients who came when they were already blind. And the tests were not very elaborate. We did only basic tests which were available, PRL, cortisol, and thyroid hormones. The types of tumors, we had productinomas mostly, followed by non-secreting tumors, and then we had 3 patients with acromegaly. The investigations, as you can see, we had CT scans done in 26 patients and MRI in 31 patients. Obviously, we can realize that some patients had CT scans and MRI as well. The operations were total debulking in about 23 patients and partial debulking in about 14 patients. The outcome, there was no death. 82% of patients were improved. They had a bit of headache. Some had blurred vision. The headaches has improved, the blurred vision as well, secondary amenorrhea, and loss of libido. Of course, obviously, blind patients never recovered. Morbidity, we had 7% of patients who had diabetes insipidus, and the visual acuity was unchanged in patients who were blind. And we had some CSF leak in 4 patients, and hemorrhage in the nostril and epilepsy in 1 patient. All those sort of small morbidities were sorted out without any problem. Now, the reason why now we choose the technique I'm going to describe to you is that within 15 months, patients with macroadenoma, particularly with supracell extension, there was a recurrence rate of 10% within 15 months. And after 5 years, the recurrence rate was about 18%. So we had to find out what was going on. I remind you that all those patients we operated early on were operated by transsphenoidal approach. This is, of course, the classification we use, the stage 1 microadenoma. Then, as you know, those are things everybody knows, so that I'm not going to expand on that. And of course, the goal of anterior skull base surgery is ideally curative surgery, where you should be able to remove a whole tumor. It reduces the brain retraction and, of course, nerve retractions as well. And theoretically, it should help to improve the vision. And we should, of course, respect the olfactory nerves, which will be not touched at all, and it will prevent also CSF leak. Now, there are different approaches, as you know. It is the traditional craniotomy approach, pterional, bifrontal, or transbasal, or orbitozygomatic. There is a keyhole craniotomy approach, which is lateral supraorbital and mini-pterional. We have the endoscopic transnasal approach. We have the endoscopic assisted transcranial approach. And of course, other people are advocating radiosurgery in some cases. As you can see in the pictures, you can use either the picture on the right side of the screen or the picture on the left side of the screen, which is the technique we are using, which is showed on the left side. And now, the primary criticism of minimally invasive is that there is more limited field of view. And people are also scared that the removal will be partial rather than really a complete removal. And you can see here a number of variants into this approach. And we had preferred the approach which is on the left side on your screen. I don't know if you can see my arrow, and we have prepared this approach. This is how we position a patient. As you can see, I don't know if you can see my arrow. You see that the head is hyperextended. You can see this axis is almost looking behind by about 30 degrees. And we slightly turn the head towards the left side, in this case. And as you can see here, there is a marking here of supraorbital nerve. It's very important to locate this structure before you do the opening. Again, this is a positioning where the patient now is ready for the operation. That's when you see on the, if you can't see the arrow, you see that on the upper left of your screen, that's the initial view of the dura. Once you've done the craniotomy, which is a small craniotomy, I'll show you the measurement. And here you see the dura has been opened on number 2. Number 3, we've started now to drain slowly and gently the CSF. And you can see already down here the visualization of the tumor. And the visualization of the tumor doesn't need necessarily to distract the brain. The brain can actually fall on its own. This is the reason why those patients are put on hyperextension, so that the brain can fall on the back. You see here the size of the flap, of the bone, which is very, very small. Now, as you can see here, supraorbital craniotomy, you see here there is a retractor. And you can see here the optic nerve, which is white on the right-hand side. And here you can see the tumor. And there is really enough space to remove all the tumor. And this is a patient after the operation. It has healed very well. And you can see, you don't have to shave actually, but we did it for various reasons. And otherwise, you don't have to shave. If you clean properly, it should be all right. So we did 35 patients with the standard supraorbital craniotomy. 12 were meningiomas, 23 were pituitary macroadenomas. And you can see here that the recurrence was in 3 patients, which was 1.3%. As you remember before, we had a recurrence rate which was 18%. You see here, for example, an example where you see the tumor before on the AP view, lateral view, and you see here the tumor after the operation. Same case here, another case where you see the tumor before the operation and the tumor after the operation. Another case here where you can see we're showing the tumor before the operation and below the study of the patient after the operation. I'm showing you also a tuberculum cellar meningioma, which was removed with exactly the same technique. You see here before the operation and AP view and lateral view, and you see here after the operation. I would like to conclude that this is some simple and affordable technique. It allows large space for microsurgery. Many surgical options consider tumor extension and reconstructions. Frontolateral approach is referable, consider bilateral exposure, possibly to combine with endoscope. But I think with this approach, you can actually operate patients with various tumors, which are actually even expanding on the opposite side, which can be very safe. But we have to remember that you need to have the minimum equipment. It means at least a microscope, which is very important. Micro instruments, instrument surgery instruments, and also it's very important to have some training on micro surgery. Thank you very much. That's the end of my presentation.
Thank you very much. Thank you for an excellent presentation. One of the first questions that's come through has been about the incision, how you make the extent of the incision you make for these craniotomies.
The incision, as I showed you, you see that the labeling I showed you earlier. Let me show you the slide. Yeah, that's where I do the incision. Can you see the arrow?
Yes, we can. Yes.
You see the arrow. Okay, that's fine. Now you see I've designed here the supraorbital nerve. You can make the incision from here up to here, but the skin, you can make a superficial incision on the skin. But when you start to cut the muscles, when you get here, you make like a U opening here before you go there, and you get the flap of muscles and you turn it there, so that the nerve remains intact, because the nerve will be embedded into that flap of muscles you've just, elevated. And then the craniotomy will be done basically here. That's the size of the craniotomy.
Well, you've kept very nicely to time, so we can take another question. But before that, I will ask a question. What's your view on the incision and where the hair follicles are? Do you try and avoid them? Do you go just above them? What do you do in terms of the cosmetic outcomes with the eyebrow?
No, I remain into the cosmetically is very good, because after that, all the hair we grow so that the incision will be completely embedded into that. Cosmetically, it's fantastic. You don't see actually the incision.
The next question is about blind spots in the with this approach. Where do you feel the blind spots are with this approach?
I think the blind spots are particularly if the tumor is too posterior. I showed you the meningioma removed. We could see it very well. So that's as far as we can go, which is quite very good. And the far lateral, if the tumor is actually invading the temporal area, that will be a limitation. But by approaching very well and draining the CSF, it is possible actually to retract gently the temporal lobe and do a lot of work on that area as well.
And the final question, oh, well, no, another question come up from Janil Gornani. He's asking about doing aneurysms. Well, the exact question is, what aneurysm can easily be done by this approach for beginners? I don't think you can say any aneurysms are easily done, but anyway, let's your answer to this question.
I haven't done any aneurysm from this approach, but I could see very well that if I found an aneurysm on the anterior communicating artery or on the it will be very easy to remove there. To clip, sorry. To clip.
May I answer?
Of course.
May I answer?
Well, Giovanni, we'll hear from you and then from Ramesh.
Okay. What for about the aneurysm? All the A1 are easily managed. The anterior communicating artery is a little bit difficult, but I did some of them without any difficulties for that. One criticism to the incision, why you go to play with the supraorbital. That is one of the most painful complication for this gentleman. I always stay a little bit lateral and I don't go where the supraorbital is present.
Well, we never had any complications, and these patients were very satisfied and didn't have any pain at all. It's very important to make sure that the retraction is not excessive. And when you follow those rules, we didn't have any problem. Patients were very, very, very good. Of course, we filtrate the skin with local anesthesia before we do this incision. And we never had any problem.
We're going to hear from Ramesh now, but I'm just going to make a comment. Ramesh and I, Giovanni, are very experienced surgeons. If you're going to approach any aneurysm through any approach, you must make sure you have proximal control, adequate exposure, and you have to tailor it to your skill level. And yes, you will see today and tomorrow some very, very skilled surgeons and what they do. But you must, of course, be very careful and tailor it to your skill level and do this carefully. Okay, Ramesh, let's hear from you.
Thanks, Sanjeev. I think you were absolutely right in saying that you can't really say it's an easy aneurysm in any case. You know, sometimes even the easy-looking aneurysm can be the deadly ones. I hear about this PCOM aneurysms all the time. Either it is dead easy or easily dead, the patient. So that's how these aneurysms are, especially the acute ones. In terms of the supraorbital approach, it's a routine practice, at least for some surgeons, to do a supraorbital approach for most of the aneurysms. So it can be done, and I have done it, and it can be done for MC aneurysm, it can be done for AC aneurysm, as well as in internal carotid artery aneurysms. But as you can remember, after we expose the supraorbital through the approach, the view you get is not very dissimilar to what you get with the TNL approach. You don't really have to expose too much of a temporal lobe. You're seeing the Sylvian fissure at the back of your supraorbital approach, and then you can dissect the Sylvian fissure. You can see the bifurcation, and you can follow the anterior artery to the ACOM. So it is possible to do it.
Good. Giovanni, anything further to add before we move on to our next speaker?
The aneurysm question is not for beginners.
Yes.
This approach has to be not done by the beginners. You have to know very well the anatomy, and for aneurysm for beginner, okay, do the SAMI approach is much better.
Yeah, this is the reason why I emphasize that we developed this technique for suprasellar tumors and the suprasellar lesions. It's a fantastic approach for those lesions. Very simple.
Absolutely.
One short comment, Sanjeeva.
Yes.
Imad, yeah.
Oh, Imad, yes, come in, yes, of course.
For the aneurysm, as Professor Boji mentioned is not for beginners and not for ruptured one. For the unruptured, some people they have attempted, but I think it's overdoing. It's better to do a proper flap to have the proximal control, as you said. Thank you.
Absolutely, I agree. I is also commented. I'm sure we'll be, of course, we're going to be hearing from him later. He may show some videos. He's talking about how you can approach the basilar as well. Again, I reiterate, these are very skilled surgeons, and you have to tailor this to your level. But we'll probably see a bit of that later as well. Now, Salman, I hope you're back. Kazadi, thank you very much for a lovely talk.
Thank you very much.
Can we undo the screen share there, please?
Okay, yes, let me